Yes, thank you very much. My name is Hamayun Imran. I'm here at University of South Alabama in Mobile. This case is a challenge for me, and I just would talk and take your time. So just bear with me because, it's like from my heart. I've been having a bit of difficulty with this family, and I'm just gonna, talk. Okay, so we'll go to next slide. This is MF. He's now 3 years of age. He was an ex-preemie. I was born to a 29-year-old, female through, a C-section. He had some resuscitation. He's the only one with FS, on the newborn screening. He has a sibling who has a trait. Nobody has sickle cell disease in the family. So we were consulted when he was 5 weeks of age. He had 78% F then and 18% S at that time. We discussed at the first visit the need for hydroxyurea and penicillin and all of that we do every time. Please, next slide. Uh, so I took the excerpts, from the visits. So the first was, after the first visit, mom is not understanding completely the newborn screening. She has a lot of questions. The baby is otherwise, very much, well, had kind of some vaccination. The mom says that she would do her own research about the medication for sickle cell disease. Okay, we said, fine. We talked about again the only FDA approved medication that would help him change the trajectory other than the transfusion is going to be hydroxyurea. She has some information on herbal medications in that visit, like chlorophyll and Evenflow. And I talked to her about the futility of these, and there's no proven therapy other than what we talked about. We ended the discussion with the thing, okay, let's just talk about it when he approaches 9 months. Next slide. 3 months afterwards, we again, talk about the same things. We have an open conversation. Um, I suggest to her that she can go to NIH uh, website and just, like look it up herself, in her spare time and see, what she finds about hydroxyurea and, kind of lack of a proven association with cancer and all of that. And we discussed, how to palpate the spleen and again, penicillin and all of that. Next slide. He had COVID, a few months afterwards. He has his first pain crisis when he was 7 months of age. He had dactylitis. The mom left against medical advice from the ED. 10 days afterwards, he returned for right arm osteomyelitis. Salmonella, bacteremia was found, and he had a 4 weeks inpatient stay. At that time, I talked about hydroxyurea. It was consented around that time, but wasn't started because the ANC was a little low. Next slide, please. A couple months afterwards, when he was 9 months, I think, we did restart the hydroxyurea, whatever the first start, but mom would not want to use it because of a fever. 10 months of age, he's found to have a hemoglobin of 2.7, platelets of 80,000, and he's fussy. He has spleen sequestration. And then, you know, kind of right about a year, the mom has questions about uh, hydroxyurea, kind of switching to monthly transfusions, as a standard of care, uh, kind of 2 years of age and splenectomy and all of that. And then, kind of she's counseled about the increased likelihood of the repeat spleen sequestration without, the chronic transfusion therapy and or splenectomy. This is another electrophoresis at that time, 4%, F and 28% S. He's already transfused. So you see the A1 as well. Next slide. He's 15 months of age. In our practice, we continue to use hydroxyurea, along with the chronic transfusion therapy if somebody was already started on it. At that time, mom, herself, kind of does inquire about the stem cell transplantation. I said, okay, we'll make the referral to Birmingham. A few months afterwards, or just a month afterward, she goes to a dentist and says that hydroxyurea, has led to rotting of the teeth, and um, she said there's no intervention by the dentist, and she's very upset about it. When he's 17 months, he has a repeat sequestration, crisis. He has some developmental delay, and at that time, I just have some adjustment of the hydroxyurea dose. Next slide. In a month's time, before we could do another transfusion, he has pain crisis and a repeat splenic sequestration. He is in the ICU. His hydroxyurea is withheld. The month afterward, his hemoglobin is fine because hydroxyurea was withheld of low platelets, all of that. It was restarted at a lower dose, about 16.5 milligram per kg. The electrophoresis is unchanged. Next slide. A month afterward, before we transfuse, he does it again. At 20 months, it's pretty sure that he would not be able to prevent this without having to have the transfusion interval decrease. So we're thinking about it. Maybe he needs kind of every 3 weeks. Hydroxyurea again has been held because the blood counts are low, uh, especially the platelets. At that time, we had the marrow consult, already done. The brother is not a match. The Birmingham team says that we have to wait until we have further complications. We take this opportunity to increase the hydroxyurea, and we continue the transfusion. And again, it's in a month. We hadn't changed it, although we talked about it. Next slide, please. A month afterwards, he does it again. He's now iron overloaded. And at that time, we realized we really need to give it to him every 3 weeks. Otherwise, it is going to be a recurrent problem, which is already there. So we still, talking about the splenectomy. We're waiting, for the immunizations to be caught up. And in the midst of all of that, one of us, decreases the hydroxyurea dose. Next slide. He's 22 months old. One of us says we need to go up on that. We have also made the referral to developmental pediatrics, and his 3 weeks transfusions have been continued. 2 years come, he gets the splenectomy, and a few months after splenectomy, the mother says hydroxyurea at night is giving him pain, and she's observed and she's done multiple trials of herself that if she holds the hydroxyurea for 3 to 4 days, he's fine. Otherwise, he gets aches and pains. We talked about other therapies that we have, but he's too young for that. And we said, let's stop hydroxyurea. Mom clearly sees an association. Next slide. Um, 1 month afterwards, we talked about the hydroxyurea is not related, has not been associated with any pain crisis. Let's just start with the low dose. So we start at 10 milligram per kg. And 1 month afterwards, he gets admitted for pain crisis. I realized from the laboratory data that he's not compliant with hydroxyurea. A few months afterwards, we say we need to go up on the hydroxyurea. His hemoglobin is 6.7. His MCV is in within range. His platelets are non-normal. He has a 4,300 of the ANC and 16% of the red count. Next slide. A few months afterwards, he gets pain and dactylitis in the ED. We gave him nasal fentanyl. We couldn't get an IV. Mom wants to leave because he feels better. He returns the same day because the pain continues. He has high platelets at that time. She declines admissions. She says that she is fully compliant with hydroxyurea. She has two other children. She needs to go, home. So we said, okay, let's discharge you on some around the clock, ibuprofen and oral opioids. Next slide, please. 7 days later, we don't have any, increase in the lab parameters that would show compliance. So I asked mom, and she becomes defensive and says, "Do I need to, take a video each time I give it to him?" I said, "No, ma'am, I really trust you, but I'm just trying to tell you what objective data we have." So we kept the hydroxyurea at 25 per kg, and we advised, well, why don't you go seek a second opinion in Pensacola? That didn't happen. And, I opted to increase hydroxyurea, the month afterwards. And the month afterward, still, there are no laboratory parameters that support it. Next slide. He's 3 years of age and he has an ED visit, and then mom reports that he's compliant. He has zero detect count. We wondered he's got parvovirus crisis. He's in the ICU. Hydroxyurea is held, and then he gets better. A few weeks, and we resume hydroxyurea at 30 per kg at that time. Next slide. A month afterwards, kind of earlier this year, he gets admitted for acute chest syndrome. He has staph bacteremia, and mom negotiates an early discharge due to the need for other children. And, he's discharged in oral antibiotics after a week or 10 days of IV. I think the ID people kind of recommended, anywhere from 14 to 21 days. I still don't see a major lab parameter that strongly supports a 30 per kg dose. We really don't look at the smear. We uh, uh, but based on the MCV and the high white count and the high retic count and lack of increment in the hemoglobin, I'm not sure if he's or she's compliant with that. So at that time, I talked to her about, he has had in 3 years so many complications, and we can't transplant him. And are we waiting on that? Why don't we just think about, putting you a simple transfusion or exchange transfusions? And she's thinking about it. At that time, we have sent another email to Birmingham to see if he has enough of the complications, so we can consider a match unrelated on a transplant. Next slide. So the question that I have for the group, thank you all of you, who have listened to me, is how can I educate her further and communicate with her that hydroxyurea compliance is in jeopardy, since the lab data don't support it. It does not, show that he's compliant. And if I'm missing anything that the group thinks that they follow, and they report compliance in that. And then I remember there's only, to my knowledge, an abstract from Abdullah Katlar that said who are the true non-responders to hydroxyurea, the ones who have a low, the ones who have a low white count and a low hemoglobin, and kind of low platelets or normal platelets. So, they, like it does, cut down your white count and your platelets, but you don't see an increment in the hemoglobin. And then I ran into a couple of articles, like from Africa, where there are genetic, kind of modifiers for poor metabolizers like DCHH2 gene that has been associated with a better response in Angolan children. And then there was another study in Tanzanian, children where, they found, 13 target genes, two for the hydroxyurea metabolism, 11 for the fetal hemoglobin production. And they had, some pathogenic SNPs that would alter the gene expression, and those were found to be higher in the non-responders. Next slide. I have these labs for you that I want you to just quickly see it. This is my best effort to pull it out, from Cerner. Um, while I was doing that, I realized that for a period of time, from January of 2023, for almost a year till December of that year or early next year, 24, he had some macrocytosis. He had some macrocytosis, but before and after, I don't have any evidence that she's giving or she's giving in the full dose, or because we have had so many interruptions, and we don't see major increment in the hemoglobin as well. Next slide.
Dr. Imran, can I stop you and ask you two questions?
Tell me.
My first question is, does he have alpha thal? Because some of those earlier MCVs are pretty small, so I'm wondering if he has alpha thal trait. That's one question. And
Okay.
the second is, are you continuing to transfuse him for splenic sequestration prevention? Have you talked about taking out his spleen?
We did splenectomy at 2 years of age.
Okay, I missed the splenectomy part. That's what I was double checking.
No
Um,
problem.
and
I
then you
didn't think of, yeah, I didn't think of the alpha tal. Do you find that the MC we had been low in the beginning? Let's go to
that's
the
what you just
slide.
showed.
Yeah, yeah. Let's go to the slides back. The one slide back.
But I think if when
Can
you
they
look at
come in?
those 50s and 60s,
Yeah. It's so we have 50s just in the month of August. And this young man would have been 12, yeah, he would have been like 8, 9 months of that of age then. Okay, point noted. We can definitely do an alpha thal gene sequencing.
but the other thing I guess is if this is obviously coming kind of between you all in terms of that patient provider relationship, why not just put him back on transfusions?
Which I have just discussed. I mean, in is that how we're gonna do for a 3-year-old? How many years are we gonna do? 6 months? Are we gonna do 1 year? Are we gonna do exchanges? Or just simple transfusion? In the next slide or so, he's already, iron overloaded.
We can treat that. We're good at treating iron overload, and maybe mom would feel more comfortable, but it might buy you some credit with family.
In terms of just that he's doing good, on transfusion, I think he's going to do good on transfusion, but what is going to be the end point?
Why do you need one? I'm playing devil's advocate that
No, no,
maybe
I mean, so my understanding, my practice, honestly, and would maybe different by many. I mean, what are some of the hard uh, kind of outcomes that we think that transfusion is inevitable? Uh, we have repeated acute chest. We have a stroke for sure. We have like a critical TCD. I understand he had, kind of the osteomyelitis and all of that. But we're talking about a number of years of transfusion. So if that's what like majority of the folks would have done for a non-compliant mom or who gives it sometimes, who doesn't give it sometime, I'm fine with that. I mean, there's going to be another, uh, 15 years of transfusions, unless, he gets transplanted or he's old enough to get gene therapy, which I'm sure, by that time, he would have. Uh, or when he becomes adult, they're not going to do transfusions for him because that's been my understanding. What
that's not true.
well, that's been my kind of understanding.
Things have changed.
Yeah, things have changed, but whatever we did in the past, we would not be able, like to sort of continue that, for the adults for so many, like for so many reasons. But I'm happy to do that if that's what it takes. And then the question would be like, do you also uh, like would continue, like with the hydroxyurea for whatever it's worth. My understanding is if I find, kind of despite the transfusion, if the retic count is high, I think like a bit of the hydroxyurea would get, would get incorporated and it's, of benefit.
Hey, I can make a couple of comments here. Clearly this patient's got a severe phenotype from the clinical course, and I agree this patient should be placed on long-term transfusion, preferably erythrocytophoresis. And to your comment about patients being on transfusion for a long time, we have had patients be on transfusion for over 20 years and continued even in the adult life for a long, long time. So that should not be an issue. But I was struggling to answer your first question as to how to best communicate to this mom. Clearly that's where you're struggling. That is a hard one for all of us, especially when we have a patient whom really we tried really hard and mom does not want to give the hydroxyurea. But on the other hand, it's also a red flag, if you will, because BMT also needs a lot of adherence issues. You're thinking transplant, you have to again continue your engagement with mom and let her know how important adherence is, especially finally if he wants to be in a state where he can be free from all the daily medicines and transfusions. That adherence part is extremely important. And lastly, I was fascinated by the genetic modifiers you mentioned.
Mhm.
That I need to do a little bit more reading about. But that's interesting that there are, even if mom says she's giving, if there are genetic factors that can influence the response to hydroxyurea. Um, but lastly, have you checked hemoglobin F levels at any time to see where we
We
were and what happened after being on hydroxyurea?
Yeah, we have had these 3 or 4 that I had in the past that I showed you guys. I wanted one, 2 weeks ago, and I think it didn't get done. I wanted to get you the most latest one. I apologize, but we'll be doing it just the end of this month, so we would see if there is any uh, improvement there.
I agree with Julie that alpha thalassemia can blunt the hydroxyurea response too. So to some extent, it's really interesting case and it's sort of a real world case.
Yeah, I
Yeah,
mean,
I
I
agree.
want to help him. And he's too young. So, the way I understood, so I'm gonna try without the the central line, but I was there on the last month's talk where um, whichever center that was, I mean, they had a lot of success without the central line. I'm not sure if the Red Cross would be able to, but I can certainly discuss that, can we do that without it? And then, we'll deal with the L immunization, as time comes.
But maybe not. If you're matching him well, right? Have you genotyped him? Have you done red cell genotyping?
We have, and then I think we, kind of blood bank director, the one, the one who gave a talk, on Echo a month or two ago. He's also on, like big on doing, the genetic one, for matching.
Hmm.
So I think if we do it, each time, maybe we can get by with a number of
Sure.
years. I think the problem.
I mean, we have many patients who, when they grew up at Children's and they stayed at Children's and got transfusions, they don't have a lot of antibodies. Some have none because
Hmm.
they're getting well matched, appropriately phenotype matched even before genotyping. So I don't think alloimmunization is a foregone conclusion.
I agree with Julie. That's been our experience too. Patients who've been on transfusion a long, long time. Many of them have not had any allo antibodies, and we don't use genotyping. Still use the extended phenotyping matching, and that's been our record. And also, we have got great success with port source as well. We used to use the Vortex ports, now Power ports. Our nurses are very good at and I have reported in the past, it's been an older paper where we have a very low incidence of central uh, line associated complications in our patients on long-term erythrocytopharesis. So it all depends on, and we don't rely on Red Cross to do our exchange. We do it in our infusion center. We have trained nurses. We've got several machines. So
We don't
relying on
have that.
somebody outside HEMONC, it's really a
Right.
disaster usually.
But we have had like a sizable population that we have transfused for a number of years. Like 2 of them got transplanted. These are the only 2 transplants from our group, like one haplo and one match, a sibling. But I also don't have had, a lot of like bacteremia or sepsis or line infections in those children. And everybody, has had a port in the past.
I
Okay.
I do think in his case, at least for now, I mean, he's young. I wouldn't do exchanges. I would stick with simple transfusions. He's clearly a hyperhemolytic kid. You don't need that exchange and then get him and get good iron chelation in him.
With, Jadenu?
Yeah, or deferriprone.
Well, I'm not sure if this mom is going to give it to him. I
Well, I think,
certainly.
but you could have that conversation. I think if you get on the same page with mom where You know, she's obviously concerned about hydroxyurea and you want to help her. So here's a way you could help her. I think it would help I would probably just help, you know, make your case.
Okay, got
That's
it.
what I would do.
Okay, got it. We'll start with the simple transfusions. We'll see how we can manage, the ferritins, and we'll go from there. And would you continue the hydroxyurea?
I never personally continue it when it's haphazard,
Uh-huh.
because I find more risk than benefit for a number of reasons that we don't really have time for. But I think that's a great question. And again, I think it goes back to you and mom too. If she really doesn't want to give it, then no, don't force it.
Got it.
That's
Okay.
just me though.
No, fine. Fine. Thank you very much, everybody. I appreciate it. Anybody else has any other comments? I saw the comments.
I actually am really sorry. We have to cut
No
cut
problem.
off comments.
No, thank you. Thank you very much.
And but that was a great case. I think, these real world situations, just be glad you don't have to deal with the 25-year-olds who make their own really bad decisions. At least in this case, you can kind of blame the mom and not the kid.
Yes. Thank you very much.
And with that, my pleasure to introduce Dr. Alfaro, who's going to be presenting on delayed hemolytic transfusion reactions in sickle cell disease. And I do want to apologize. You all may have heard that we've had some federal issues with funding lately, and I have to go join an emergency meeting on that. So I'm going to leave Sonia in charge and to run things from here on out, but happy to help in any way I can, answer questions later. So thanks to all. And Dr. Alfaro, all you.
Can I just take 30 seconds to introduce her? She's a current PGY2 categorical pediatric resident at the University of Louisville. She's from Texas and has some interest in global health and preventative medicine. She's interested in pursuing a career in pediatric hematology and oncology and will be applying for fellowship this upcoming cycle. Take it away, Dr. Alfaro.
Thank you, Dr. Raj. So my name is Alyssa Alfaro, and today I am going to be talking about delayed hemolytic transfusion reaction in sickle cell disease patients. Transfusions can be life-saving treatments for patients with sickle cell disease. However, finding available matched units can be limited due to distinctive blood group polymorphisms that can be found in patients with African descent. Development of antibodies against these transfused red blood cells can result in a delayed hemolytic transfusion reaction, which can be life-threatening and currently has limited recognition due to presenting symptoms very often mimicking vaso-occlusive pain crisis, as well as having frequently undetectable antibody levels, which has resulted in limited established incidence as well as transfusion management protocols. So in this presentation, I am going to review current literature on the definition, clinical presentation, the lab workup, pathophysiology, management, and prevention for delayed hemolytic transfusion reactions. Next slide, please. So the main clinical presentation in these symptoms can often mimic vaso-occlusive pain crisis, which can lead to delayed diagnosis. Symptoms can appear anywhere from 3 to 10 days after the inciting transfusion. There can be signs of accelerated hemolysis, such as significant hemoglobinuria. Jaundice can also be seen in these patients. And then associated lab values include a significant drop in hemoglobin levels greater than 2 to 4 grams per deciliter from their baseline, elevated LDH and bilirubin, as well as a paradoxical reticulocytopenia that can be seen, as well as some decreased haptoglobin levels seen with hemolysis. These patients can also develop fever during these delayed hemolytic transfusion reactions, which often can be in conjunction with other complications, such as acute chest syndrome, further complicating the presentation. Additionally, there can be multi-organ failure in severe cases, which is due to uncontrolled hemolysis and inflammatory responses, which I will review a little bit later. Next slide, please. So diagnosis for delayed hemolytic transfusion reaction, in addition to the lab values that you would expect to accompany with hyperhemolysis, diagnosis can be done through the detection of the antibodies. Most importantly, it can be done with monitoring hemoglobin A levels. In this graph, we can see at the bottom box the presence of the antibody levels rise during primary alloimmunization, which I will discuss a little bit more later. Then they can wane and then rapidly rise with secondary alloimmunization. In sickle cell disease patients during delayed hemolytic transfusion reactions, when the antibody levels are high, you can see that the patients have a rapid decline in their hemoglobin A as the transfused red blood cells are attacked. Then with hyperhemolysis, patient's own blood begins clearing rapidly, shown with a continued drop in total hemoglobin on the top of the graph, as well as hemoglobin S levels. And again, there can be a severe anemia with these patients. There can be presence of the serological markers of alloantibodies with DAT in some cases, although I found up to 30% of these delayed hemolytic transfusion reactions can be alloantibody negative. The most accurate way to know that a reaction is happening is with serial hemoglobin electrophoresis to monitor those hemoglobin A levels. There is a nomogram available online that was proposed by Dr. Mykonos Desap that actually can help diagnose delayed hemolytic transfusion reactions by risk stratifying them in these sickle cell disease patients by plotting the relative change in hemoglobin A concentration and the time that's elapsed since transfusion, and it categorizes it into a low, intermediate, or high risk, and you can just Google it online. Complement activation additionally has been seen to play a role in the pathophysiology of delayed hemolytic transfusion reaction, and so flow cytometry can additionally be performed to evaluate for complement deposition, primarily the MAC complex C3 through 5, which again I will discuss a little bit more later. You can go ahead and go on to the next slide. So cytokines that are involved in the pathophysiology, there currently isn't a specific cytokine panel that can be ordered, but there are certain cytokines that have been shown to have large roles in the pathophysiology. In a 2020 prospective study of sickle cell disease patients, it was found that IL-6, IL-10, IP-10, and macrophage inflammatory protein were significantly higher in the plasma from sickle cell disease patient than from healthy controls, regardless of their clinical context. During delayed hemolytic transfusion reaction, pro-inflammatory cytokines such as IL-6, IL-8, and TNF-alpha can be elevated. IL-10, an anti-inflammatory marker, can sometimes be used to trend and be able to determine the response to treatment, in addition to monitoring for the resolution of hemolysis when treatment is started for these patients. In the complement activation in delayed hemolytic transfusion reaction, C5a and the terminal complex C5b through 9 levels are significantly elevated, which I will discuss in the pathophysiology. Next slide. So this graph shows what we assume is happening in a typical delayed hemolytic transfusion reaction. A patient has exposure to red blood cell antigen through either transfusion or pregnancy, and they make antibodies as a primary immune response, typically not causing red blood cell destruction that first time. These antibody levels decrease over time, which likely prevents their detection prior to subsequent transfusions when cross-matching screenings are performed. Patients can then be inadvertently re-exposed to the red blood cell exposing the same antigen that they have previously made antibodies to, which can result in a secondary amnestic memory-based antibody response, which results in those antibodies coming back at a significantly higher level, which can cause accelerated clearance of the transfused red blood cells in these patients, resulting in hemolysis and a delayed hemolytic transfusion reaction. During this time, you can detect the antibodies if the antibodies are able to be detected, but again, there have been cases in which they have been antibody negative. Antibody-induced clearance of transfused red blood cells can occasionally result in hyperhemolysis, otherwise known as hyperhemolytic syndrome, which is signified by the accelerated clearance of the patient's own red blood cells, resulting in a fall in hemoglobin below pre-transfusion levels. Next slide. So continued pathophysiology, the alloantibodies that develop in response to the exposure to alloantigens can lead to direct clearance of the red blood cells through a variety of antibody effector mechanisms, such as the activation of the complement system. Delayed hemolytic transfusion reaction can additionally occur, as I have mentioned, without any detectable alloantibodies. They either have been thought to be below detection levels or absent entirely. With delayed hemolytic transfusion reaction possibly having some heme-mediated complement activation, there is red blood cell intravascular hemolysis that can also be seen, which leads to the severity of this condition. Whenever there is a release during intravascular hemolysis of free hemoglobin and free heme, haptoglobin and hemopexin, as well as hemooxygenase, become overwhelmed. This results in the accumulation of free heme that generates oxidative stress, which can trigger the symptoms of the vaso-occlusive crisis, which can make it particularly hard to diagnose our presentation. This free heme can also accentuate damage to vascular endothelial cells by acting as danger-associated molecular pattern molecules. They can activate toll-like receptor 4 on endothelial cells as well as immune cells, and further result in the release of pro-inflammatory cytokines such as IL-6, TNF-alpha, and IL-8. Whether this hyperhemolysis is occurring through classic or alternate pathways of complement activation, you can have some membrane attack complex formation. It is the predominant mechanism that is presumed to be happening during the hyperhemolysis and these delayed hemolytic transfusion reactions. The patient's red blood cells are also destroyed because they are sensitive not only to the oxidative stress that is caused by the release in the excess heme, but also the non-specific binding of these complement fractions, which again further increases oxidative stress, resulting in suppression of erythropoiesis, which can result in paradoxical reticulocytopenia that can be seen in these patients. Next slide, please. Acute management for these patients, the most important thing is going to be supportive care, which includes IV fluids, keeping them well hydrated, pain control, with paying special attention to avoid excess opioids to prevent hypoventilation, stopping further transfusion to prevent further hemolysis, and enhancing oxygen delivery to tissues, whether using just a simple nasal cannula or a non-nerve breather. I even saw case studies of recommending oxygen supplementation, even if there isn't any hypoxia that is seen with regular SpO2 monitors because of the severe anemia, further resulting in decreased oxygen transfusion to the tissues for these patients. Erythropoiesis can also be helped by giving EPO as well as folate supplements. It has been used to boost red blood cell production in times of the severe anemia. Plasmapheresis has been attempted to reduce the free heme levels, although it is limited by severe anemia of the patient and inability to further transfuse patients. There is immunomodulator therapies such as IVIG and steroids that further help reduce hemolysis in the setting of delayed hemolytic transfusion reactions. IVIG aids in reducing complement-mediated hemolysis by blocking the FC receptors as well as by suppressing macrophages, which have a large role in pathophysiology. Use of corticosteroids is still debated, although I did see some case studies showing that higher dose corticosteroids have actually helped patients when they're in these states of hyperhemolysis. Complement inhibitors can additionally be used. Eculizumab is an anti-C5 complement blocking antibody that has been shown to reverse complement activation and prevent formation of the membrane attack complex. It has additionally been shown to reduce hemolysis and has resulted in rapid clinical improvement, which I will touch on in just a little bit. It does require meningococcal vaccination prior to use. An additional complement inhibitor that can be used is pegosilofan, which is a C3 inhibitor. It has been shown to block upstream complement activation, which thus reduces further red blood cell destruction in these patients. There are currently clinical trials for the use for other hemolytic disorders at this time for it, and it is both effective in intravascular and extravascular hemolysis. Next slide. So these are some pictures from a patient at Norton Children's Hospital. This patient was experiencing hyperhemolysis and had failed to respond to IVIG, steroids, and rituximab. The picture on the top is the patient's urine prior to treatment. The pictures on the bottom, going from left to right, represent 12 hours after treatment with eculizumab, 24 hours after treatment, and 36 hours after treatment. So you can see the rapid response by blocking that complement activation with using the eculizumab, which helped stop the hyperhemolysis that can be seen. Next slide, please. This graph is a little bit blurry and a little bit difficult to read, but I wanted to include it because it highlights the complement activation. So it is from a patient who had 3 delayed transfusion reactions. The patient's second presentation of this was notable for some hyperhemolysis as well as multi-organ involvement, and those values can be seen on the far left slide. You can see that they have significantly elevated complement levels, the anaphylotoxins C5a, as well as the terminal complex. And you can compare all the way to the last row, which is after their third presentation. They were in clinic and had since resolved, and they had significantly decreased levels. The middle 2 rows are her third presentation for this delayed hemolytic transfusion reactions. She had a severe presentation at that time. They gave high-dose steroids, IVIG, 4 doses of rituximab, and the 2 values represent before treating her with 2 different times that she required eculizumab. And you can see that the complement levels remained elevated all the way until resolution with her clinic follow-up in the very, very last column on the far right. Next slide, please. So some prevention for this. Preventative measures are thought to be, of course, keeping track of reactions through like blood blank alloantibodies from reactions that patients have had in the past. This can be, however, limited if patients seek care at multiple medical facilities and they receive transfusions at multiple different locations and their transfusion reaction history is not available at the time of presentation. If a patient has a known history of it, you can perform extended phenotype matching against FY, JK, and SS. In cases where a clinical status necessitates consideration for a least incompatible red blood cell transfusion based on clinical presentation, rituximab can be used prophylactically. It has been described to reduce delayed hemolytic transfusion reaction in case reports. It's not indicated in the prevention of alloantibody negative delayed hemolytic transfusion reactions, but it can limit development of new red blood cell antibodies. These patients, if they do receive rituximab, it's important that they are up to date on antipneumococcal vaccines as well as penicillin prophylaxis, especially until their CD19 B cell counts recover. Currently, the standard of care at many centers is to transfuse these sickle cell disease patients with leukodepleted red blood cells that have been extensively cross-matched for Rh, D, big C, big E, little c, little e, and K antigens. With that, 45% of chronically and 12% of episodically transfused recipients can still become Rh alloimmunized. If available, genotyping can also be considered for these patients who have a history of antibody-negative delayed hemolytic transfusion reaction. Next slide. I just wanted to briefly touch on some emerging therapies. There are heme scavenging molecules such as hemopexin concentrate that are being looked into to help neutralize the free heme as well as dampen the toll-like receptor 4 activation and as well as haptoglobin concentrates. They're not commercially available right now, and I'm not aware of any clinical trials, but they have been proposed. There are also JAK-STAT inhibitors that can help target cytokine signaling pathways such as tocilizumab, which is an IL-6 receptor blocker that indirectly inhibits the JAK-STAT pathway by blocking IL-6 signaling. Next slide. Are there any questions? If not, the next slide is just my references.
Thank you, Elisa, for presenting. Please feel free to share your thoughts and encourage Elisa for her great presentation today.
Hey, so that was great. My name is Tarun Arora. I'm a junior faculty at Emory and Choa in Atlanta. This was great. It's very helpful for me to re-review, I should say, the DHTR pathophysiology. And I really like your reference at the beginning. My guess is that you're referencing Dr. Stella Chu's article about how when she did a great sort of retrospective review, they found out of hundreds of patients that about 30 to 35% of them actually had undiagnosed DHTR. And so it's something that after that article, I became hyper vigilant about anytime I get consulted on a patient with low hemoglobin with sickle cell. I'm curious with your reading or with others on the call, what their experience with bortezomib is. I've been using that more and more frequently. It's a common practice at Emory, but it wasn't a common practice where I trained. So I'm curious if you read anything about it, and then if others on the call use it regularly, either to prevent it. I usually use it in the setting of somebody who's heavily alloimmunized or has a history of DHTR, but not in the acute treatment. So just curious about that.
I did not actually see that come up in my reading. So I don't know if somebody else can join in.
So I will be also in the same category because we have not used bortezomib in this context. Like we have used all the medicines that Lisa alluded to, but there could be a role for bortezomib, like in difficult patients. Sometimes when you're facing a life-threatening situation, you're really, really lost. What is it that you can do? So maybe you can tell us your own experience with bortezomib. How did the patient do after you gave the medicine, if you want?
Yeah, for sure, for sure. So Lisa, for you, if you're not familiar with it, bortezomib is commonly used in like certain malignancies, liquid malignancies, like multiple myeloma. I think it's like a proteome inhibitor. I don't remember exactly what it acts on, but it definitely helps to dampen down the immune system and an overactive immune response. And so, kind of just through practice here at Emory, there's like a algorithm that we go through for patients who have had a history of DHTR and need blood. Let's say they present with a hemoglobin of 4 and have like severe symptoms and we need to transfuse them, but we can't find perfectly compatible blood. So we find the least incompatible blood. We pre-treat them with steroids, high-dose steroids, IVIG, and bortezomib, and then we transfuse. And the 3 times I've done this in the past 6 months, the patients have done beautifully. So I will say at our practice, in the adult side, I can't speak to the ped side. It's worked out very well with my NF3, and historically, it's worked well with the other providers at Emory.
I guess much of the experience with bortezomib comes with by rheumatologists, right? When they're treating SLE patients and they want to deplete the plasma cells and reduce the antibodies. So outside SLE, I think, and of course, multiple myeloma, like you mentioned, I think there is just it's an emerging area to see more and more research to be developed there.
Hi, Tarun, it's Yogi. When you use bortezomib, do you use the same 375 milligram per meter squared at like 1, 3, 5, 7, 11, or do you do like what's your dose schedule?
So I think the 375, I thought 375 was Ritux, but because of Bortez, I use, I think 1.2 to 1.5 mgs per meter squared, and that's going to be at day 1 and day 3, and then we transfuse. I
Got
could
it.
not tell you if that's based in literature. It's what we do and it's what's worked. So I'm happy to send you our kind of like shared email protocol that we have amongst the providers here. Again, not wholly based in evidence, but it's working.
Yeah, I've
Subs.
used
Sorry, go ahead.
bortezomib in like AIHA patients. It has worked well, but I've never used it in DHTR, and so I'd be interested to see what your protocol is like.
So, like, how long have you used it for? You said you use it for a 10-day
Oh
cycle?
no,
Or...
just 2 days pre-transfusion. That's it. And then we don't repeat it. At least I haven't. So it's just a couple, it's almost like a pre-treatment.
So day -1 and day -4 pre-transfusion?
Something like that. Yes. Yeah, something like that. Yeah.
Okay.
That is good information. I didn't know that.
Yes. Absolutely. I'm happy to email it to I mean I can get our providers here to put together something and send it to the UAB Echo folks to send out on the listserv if it's helpful for people.
Okay. Thank you.
Yes, thanks, and I'll be on the lookout for that. Any other comments? All right. Well, thank you to both of our presenters for today. Really enjoyed the discussion. And once I receive that information, I will send it out to everyone along with a recording from today's Echo. So thanks again and have a great evening, everyone.
Thank you all.